Welcome. This module will introduce you to the principles of lung mechanics and the importance of spirometry. Before specifically looking at the mechanics of the lung, it is important to understand the structures that allow it to work. The lungs are contained within the thoracic cavity, extending from the diaphragm to just slightly superior to the clavicles, lying against the ribs anteriorly and posteriorly. Here, the lungs seen from the front are being inflated by air to maintain their shape. This is the trachea, and these are the principal bronchi. The narrow superior portion of the lung is the apex, and the wider inferior portion is the base. Between the two lungs lies the heart and great blood vessels. Each lung has three surfaces. The medial or mediastinal surface is marked by the hilum, where the bronchi, blood vessels, lymphatic vessels, and nerves enter and exit. The concave inferior surface rests on the diaphragm, and the large convex costal surface faces the rib cage. Each lung is divided by deep fissures into lobes. The right lung has three lobes, superior, middle, and inferior, whilst the left has only two, superior and inferior. From behind you can see the fissures separating the lungs extend all the way round onto the mediastinal surfaces. Between the lungs posteriorly lie the vertebral bodies. The respiratory tract forms a branching hierarchy consisting of the trachea, the primary bronchi, the secondary bronchi, the tertiary bronchi, the bronchioles, and finally the terminal bronchioles at the very end. The primary bronchi are outside the lungs and are therefore known as the extrapulmonary bronchi, whilst those within the lungs are known as the intrapulmonary bronchi. As you can see here, each lobe receives its own secondary bronchus. Therefore, the right primary bronchus gives rise to three secondary bronchi, superior, middle, and inferior, and the left primary bronchus gives rise to two secondary bronchi, superior and inferior. Relaxation of smooth muscle in the bronchioles allows bronchodilation for greater ventilation, whilst irritants or other stimuli cause constriction of the smooth muscle, known as bronchoconstriction, which decreases ventilation. Here you can see the alveoli, the tiny air spaces where gas exchange occurs. Notice that they open and close progressively as the lung is inflated and deflated. Bronchioles subdivide into microscopic tubes called alveolar ducts, like the stem on a bunch of grapes. Each alveolar duct ends in alveolar sacs, which resembles a cluster of grapes, with the wall of each alveolar sac made up of numerous alveoli, which resembles a single grape. Each alveolus is in contact with a capillary. Diffusion of oxygen and carbon dioxide across the alveolar and capillary walls is very easy due to being very thin, allowing effective gas exchange. Collectively, the layers through which respiratory gases diffuse are known as the alveolar capillary membrane. The surface of the respiratory membrane is covered in surfactant that reduces surface tension within the alveoli, preventing it from collapsing as exchange occurs across the membrane. Here you can see discoloration caused by damage to the lungs by smoking. The area in between the left and right lungs is known as the mediastinum. This is occupied by the heart and great vessels, as well as by fat and lymph nodes, and in childhood by the thymus gland. The compliance of the lungs is an indication of their expandability, or how easily the lungs expand. The lower the compliance, the greater the force required to fill the lungs. The greater the compliance, the easier to fill the lungs. Factors affecting compliance include the following: the connective tissue of the lungs, the level of surfactant production, and the mobility of the thoracic cage. The surface of the lung is formed by the visceral pleura. The visceral pleura is a connective tissue covering the lung completely, except at the hilum, where it becomes continuous with the parietal pleura. When the lung collapses, you can see the two separate pleural surfaces, parietal and visceral. The two normally slide over each other with nothing between them except a film of serous fluid. The mechanics of the pleura work by the fluid providing mechanical coupling between the two pleural surfaces, allowing instantaneous transmission of perpendicular force between them. Mechanical coupling working in a similar way to a glass coaster sticking to a slightly damp glass. A thin film of fluid between two smooth surfaces creating a partial vacuum that forces the two surfaces to cling to one another, whilst also allowing them to slide against each other. A similar situation occurs between the two pleural surfaces during breathing as the lungs inflate and deflate. Now we are going to look at the muscles that allow respiration to occur. Here you can see the ribcage and the intercostal muscles. Notice the fibers are directed obliquely, with external internal intercostal muscles running in opposite directions. Removing the intercostals, you can see the ribs and the cartilage that project from each to complete the ribcage. Also, you will notice the movement of the pleura in situ as discussed before. Changes of volume in the lungs take place through the contraction of skeletal muscles, specifically those that insert onto the ribcage, and the diaphragm which separates the thoracic and abdominal cavities. The most important skeletal muscle involved with respiratory movement is the diaphragm and the external intercostal muscles. These muscles are active during normal breathing at rest. The others are accessory respiratory muscles that become active when the depth and frequency of respiration must be increased markedly. Muscles of inspiration include the diaphragm, the external intercostals, the sternocleidomastoid, the scalenes, pectoralis minor, and serratus anterior. The muscles of expiration include the diaphragm, the external intercostals, the internal intercostals, which can be subdivided into two, the internal intercostal muscles, and the innermost intercostal muscles, transversus thoracis, and the abdominal muscles, which is the rectus abdominis, transversus abdominis, and the external internal obliques. To see more information, see the in-depth section.